Management of Relapsed or Refractory Large B-Cell Lymphoma. A British Society for Haematology Guideline. First published, the 19th of May, 2025. Disease Assessment and Prognostic Factors at Relapse. Recommendations for assessment of relapsed large B-cell lymphoma. Record performance status for all patients with refractory or relapsed large B-cell lymphoma. 1b. Perform restaging with PET-CT, 1a. Perform a repeat tissue biopsy, unless clinically unsafe, to confirm histology and assess CD20 expression prior to each line of treatment. 1b. Consider evaluating CD19 expression at relapse following CD19 targeting therapy. 2b. Assess risk of tumor lysis in all patients and manage as per current BSH good practice paper. 1b. Second-line treatment. Recommendations. Assess eligibility and fitness for CAR T-cell therapy and high-dose therapy autograft in all patients with relapsed and refractory LBCL. 1a. For CAR T-cell fit patients with primary refractory or relapsed disease less than or equal to 12 months of completing first-line chemoimmunotherapy, offer CD19 targeting CAR T-cell therapy. 1a. For high-dose therapy autograft fit patients relapsing greater than 12 months after completing first-line chemoimmunotherapy, offer a platinum-based regimen, e.g. RICE, RGDP, RDHAP, RESHAP. 1a. Assess response to reinduction with a PET-CT scan after 2 to 3 cycles. Offer high-dose therapy autograft for patients achieving a complete metabolic response. 1a. For patients in partial metabolic response, the approach requires individualization. Consider high-dose therapy autograft for patients with a low tumor burden Duville-4 response. 2b. Consider radiotherapy consolidation before or after HDT auto for patients in partial metabolic response after reinduction chemotherapy. 2b. Offer third-line therapy, preferably after further biopsy, for patients with an inadequate response or for those with stable or progressive metabolic disease after 2 to 3 cycles of reinduction. 1a. For patients who are not suitable for second-line CAR T-cell therapy or high-dose therapy autograft, treatment should be individualized based on the level of fitness of the patient, prior first-line therapy and potential suitability for CAR T-cell therapy or anti-CD3x/CD20 bispecific antibody therapy in the third-line setting. 1b. Offer glofitamab plus gemcitabine and oxaliplatin if available. 1a. Consider rituximab-containing regimens without bendamustine such as 4 to 8 cycles of gemcitabine and oxaliplatin, especially where subsequent CAR T-cell therapy or anti-CD3x/CD20 bispecific antibody therapy may be appropriate at third line. 2b. Consider Pola-BR for selected patients who have not received polatuzumab in first-line therapy, but caution is advised with bendamustine where subsequent CAR T-cell therapy, and possibly anti-CD3x/CD20 bispecific antibody, may be appropriate at third line. 2b. Where available, consider tafasitamab and lenalidomide for selected patients, but caution is advised where CD19 targeting CAR T-cell therapy may be an option in third-line setting. 2b. In frail patients, consider oral etoposide-based chemotherapy regimens with or without rituximab, see next section. 2b. Third-line and subsequent treatment. Patients may require third-line therapy after different treatment paths. After second-line CAR T-cell therapy. After second-line intensive platinum-based multi-agent chemoimmunotherapy with or without HDT auto. After less intensive chemoimmunotherapy regimens, having been deemed unsuitable for both second-line CAR T-cell therapy and HDT auto. Recommendations. Offer referral for supportive and palliative care as appropriate, in consultation with the patient and their carers. 1c. For CAR T-cell fit patients not previously treated with CD19 targeting CAR T-cell therapy, offer third-line CAR T-cell therapy. 1b. Offer anti-CD3x/CD20 bispecific antibody therapy with epcoritamab or glofitamab to patients considered not suitable for CAR T-cell therapy. 1b. For patients relapsing after second-line CD19 targeting CAR T-cell therapy, see section below on the management of post-CAR T-cell relapse. For patients not suitable for either CAR T-cell or anti-CD3x/CD20 bispecific antibody therapies, alternative treatment options include pola-BR, loncastuximab, tafasitamab lenalidomide, low-dose chemotherapy and supportive care. 2b. Consider palliative radiotherapy for symptom and disease control. 2b. Patient selection and bridging to CAR T-cell therapy. Recommendations. Consider the need for holding and/or bridging therapy based on disease-specific factors such as tumor burden, distribution, and rate of progression. 1c. When choosing holding bridging therapy, consider patient-specific factors, such as prior treatment, physiological fitness and comorbidities, and therapy-specific factors, such as washout periods prior to apheresis and/or CAR T-cell infusion, and potential effects on CAR T-cell manufacturing and treatment outcomes. 1c. Options for holding bridging therapy include involved site radiotherapy, corticosteroids, chemoimmunotherapy, typically a single cycle of a non-cross-resistant regimen e.g. RGDP, pola-BR, or combined modality bridging with radiotherapy for bulky sites plus systemic corticosteroids or chemotherapy. 2b. It is preferable to avoid bendamustine in holding therapy prior to apheresis. 2b. Management of post-CAR T-cell relapse. Recommendations. Consider referral for supportive and palliative care. 1c. Perform biopsy, unless clinically unsafe, to confirm refractory or relapse large B-cell lymphoma and assess CD19 and CD20 expression. 1b. Choice of further therapy is dictated by any ongoing cytopenias or other toxicities post-CAR T-cell therapy, patient fitness, prior treatment and response, stage and rate of disease progression. 1c. Offer anti-CD3x/CD20 bispecific antibody therapy, epcoritamab or glofitamab, for suitable patients. 1b. Consider radiotherapy for selected patients. 2b. Other options include pola-BR, platinum-containing regimens, and loncastuximab. 2b. Consider consolidation with high-dose therapy autograft for eligible patients progressing after second-line CAR T-cell therapy who have chemosensitive disease. The role of transplant consolidation after anti-CD3x/CD20 bispecific antibody therapy is unknown. 2c. Although there remains significant uncertainty and concerns about toxicity, consolidation with an allograft may be an option for selected young and fit patients relapsing after third-line CAR T-cell therapy, who achieve a further remission. 2c.